Hello everyone, my name is Eric Westerman and this is my capstone project. It is on assessing the impact of passive disinfecting port caps in reducing central line associated bloodstream infections. For my first slide, my introduction, CLABSIs lead to an increased rates of preventable morbidity and mortality. They lead to longer hospital admissions due to extended recovery, and they require more frequent invasive medical treatments due to the higher acuity. CLABSI patients face life-altering complications they didn't have before they entered the hospital. These longer admissions mean more time away from family and more time exposed to the risks of a hospital environment. A preventable infection leads to higher acuity, which means more invasive tubes, lines, and meds. These further increase the risk of new complications. Next, financial burden. Hospitals absorb the full cost of care for CLABSIs. The cost per CLABSI is about $50,000, and this is due to medications, extended length of stay, monitoring. CLABSIs are classified as preventable, so insurers often won't pay for the extra care. The hospital is responsible for the error. This places significant strain on resources. This includes antibiotics, 24/7 bedside nursing, laboratory tests, and increased length of stay. And finally, the impact on healthcare staff. The increased workload required for managing CLABSIs requires added medications and more monitoring and time redirection. This time is shifted away from routine care to manage acute complications. These patients require monitoring, specialized dressing changes, and additional medication administration. This time could be spent elsewhere, including providing preventative care for other patients. So my intervention would be passive port caps. These caps contain a sponge that is saturated with 70% isopropyl alcohol that twists onto the hub of central lines. The caps offer continuous disinfection and a physical barrier while central lines are not in use. The caps maintain a sterile surface for up to 7 days if undisturbed, and then they require to be switched out or changed. And if a patient has a central line and they're going up to 7 days without use, it should be discussed whether the line is needed or not. This also eliminates human error associated with the scrub the hub duration. So these caps are a constant aseptic bath for central lines. The sponge is in direct continuous contact with the injection site. Aside from chemical injection, it acts as a shield. The caps prevent airborne contaminants, dust, or accidental touches from reaching the port surface. So my goals would be to reduce the length of stay, improving bed turnover rates, and reducing the risk of secondary hospital infections that occur during prolonged stays. 90% staff compliance. Passive disinfection is only effective if the caps are on the lines. 90%. This goal acknowledges the realities of bedside nursing while still holding staff to a high standard. 100% would be ideal. However, emergency situations and patient decompensation is included to allow a little bit of a buffer, which is why 90% is my goal. And return on investment. Demonstrate that investing in disinfecting caps pays for itself by avoiding the high costs of treating preventable infections. So regarding reducing length of stay, the goal is to discharge patients home based on their primary diagnosis, not because of a complication they acquired in the hospital. Preventing infections will keep the beds moving, which helps with unit flow and capacity. The longer a patient stays, the higher their risk for other secondary infections. For staff compliance, this is a best practice goal that acknowledges the unpredictable nature of bedside nursing, and it still pushes for excellence with that 90% compliance goal. And then finally, return on investment. Prevention pays for itself by avoiding non-reimbursable treatment costs. So if you remember, the cost of a single CLABSI estimated about $50,000, which could theoretically pay for all of the caps for an entire unit for a year, just one CLABSI. For implementation, so prior to rollout, I would want nurses will demonstrate peeling the seal and twisting the click to ensuring a secure lower lock of the caps on the hub. Data from previous slides will be presented to staff, including the length of stay increase, the morbidity, mortality, and this will highlight the importance of compliance. So hands-on practice, this will allow staff to familiarize themselves with the product in a contained environment. They will be able to ask questions and demonstrate application prior to using this in real life and clinical practice. Before implementation, showing the data and the length of stay mortality will highlight that this just isn't another task, it's about preventing real complications. For the rollout, launch will occur in the CICU prior to a hospital-wide go live to work out logistical kinks. So the CICU is a high acuity environment where most, if not all, patients have central lines and will give good evidence on whether this is appropriate or not, and will have multiple patients with multiple central lines. So this phased out approach using this unit as the starting point will help set the standard for the hospital-wide rollout. And then compliance tracking, instead of checking charts, the auditor simply will walk down the hall and look at the lines. Unit compliance will be determined by the number of patients, lumens, and the amount of caps. So example, if there's 10 patients and there are 30 lumens total, if 27 of the lumens have caps, the unit is at 90% compliance. So real-time eyes on audits are fast and accurate. This allows for education and reinforcement to happen immediately instead of someone looking through the charts and then going and finding the nurse, and theoretically the nurse could chart that the CHG cap is on the line and then it's not actually on the line. So this allows for real-time feedback. Challenges that I would expect. Changing long-standing practice is always an issue. Staff may continue to use alcohol pads out of habit but forget to apply the cap, or they may apply the cap without ensuring the hub was clean first during the initial transition. So the solution I have for this is during shift handoff, it will be a standard part of the bedside report to look at the hubs together, which nurses should be looking at central lines during shift handoff to ensure that the dressing isn't saturated or the lumens are connected as they should be, so this will just be added on to that. For accessibility, if the caps are only kept in the clean utility room or they aren't stocked on the IV poles, nurses in a rush will skip them. So if they run out of the caps, they may not feel the need to go all the way down the hall or wherever to grab the caps to place on the line. So my solution for this is that caps will be stocked in the same bins as saline flushes. You need a saline flush to access a central line. So if the caps are in the same area of those, it will become second nature to grab both of them to ensure they're both at the bedside. Another challenge would be reduced vigilance. So nurses might skip other components of the CLABSI bundle, such as hand hygiene or dressing integrity, believing that this cap will handle all of the disinfection needs, which is not true. This is an added protection on top of the central line bundle that is always in place. So my solution for this would be education to reinforce that the cap is only one part of the bundle. It protects the hub, but it doesn't protect a soiled dressing or poor hand washing habits. And then cost perception, this is my final challenge, and this is the budget for supplies will go up immediately from purchasing these caps, but the cost savings from prevented infections might not be visible for 6 to 12 months. So my solution for this would be data regarding passive cap price versus one CLABSI will be shown, and this will demonstrate that preventing just one CLABSI pays for several years worth or a year's worth of caps for the entire unit. So for evaluating success of this project, so CLABSI rate success will be determined by comparing the rate of infections per 1,000 central line days against the unit's historical baseline. So my calculation for this will be number of CLABSIs divided by the total central line days multiplied by 1,000. So measuring success by the number of infections per 1,000 central line days allows us to compare our progress directly against the unit's historical baseline. For compliance, visual audits of all central line hubs on the unit will occur. This gives us an immediate idea regarding staff adherence to the new protocol. Length of stay evaluation. Success will be defined by moving closer to the expected length of stay for the primary diagnosis rather than the extension typically seen with the CLABSI. So if a patient comes in experiencing an asthma exacerbation and they develop a CLABSI, we would want them to theoretically have the length of stay from just the asthma exacerbation and not the added need based on the central line infection they received inpatient. So the goal is to see patients discharged on their primary diagnosis timeline. return of investment. So the monthly cost of the disinfecting caps will be tracked, and the calculation would be the total spend on caps divided by the estimated avoided costs. And this is using about $50,000 per CLABSI benchmark. So with the average CLABSI costing around $50,000, it only takes preventing 1 to 2 infections to show that this project will pay for itself. So for my synthesis of literature, key findings found from the articles that I reviewed for this project, 7 out of 8 evaluated studies reported a significant decrease in CLABSI rates following the implementation of disinfecting caps. The disinfecting caps consistently outperformed or matched standard manual cleaning protocols, such as scrubbing hubs with chlorhexidine gluconate solutions. And then across the positive studies, the reduction in infection rates ranged from 22 to 73%. The study duration and sample size varied, but all showed positive results. So the lowest success rate in these studies showed a 22% reduction in infections, and this is still a large improvement from before. And these caps will help eliminate human error associated with manual hub scrubbing as a sole disinfection method. So this is an added protection on top of the central line to prevent infections. And although the studies varied in size, the positive direction of the data never wavered. And consistency across all study durations suggests that adherence to the protocol provides long-term and sustained protection. So my evidence-based practice recommendation is that disinfecting caps provide a stronger barrier against hub contamination compared to the traditional manual disinfection alone. Consistent cap usage can reduce CLABSI rates by up to 73%. The average cost of a single CLABSI is around $45,000 to $50,000 in non-reimbursable expenses. Disinfecting caps offer a rapid return of investment because preventing one infection far outweighs the price of supplies. So manual disinfection only works when you scrub. This cap provides 24/7 active disinfection for up to 7 days prior to needing changed out. This ensures the hub is cleaner the longer it stays on. A 73% drop means fewer ICU stays and less reliance on high-dose antibiotics. And $50,000 is the starting point. Because these infections are non-reimbursable, that money comes directly out of the hospital's operating budget. So theoretically, a patient could come in for heart failure exacerbation, have the central line placed for Milrinone initiation, they develop a CLABSI. This CLABSI could lengthen their hospital admission, and they're exposed to other bacterias, other patients, other sources of contamination, and this could increase their hospital stay longer and add on to this price. So if these caps just prevent just one single CLABSI, they've already paid for an entire unit supply for a year, if a CLABSI is about $50,000. So for my conclusion, this project demonstrates that by altering a basic nursing task, we can improve patient outcomes, reduce clinician burden, and protect the organization's financial health. To the right of this, I have a picture from one of the studies I evaluated, and it just shows the disinfecting cap versus standard technique of scrubbing the hub, and it reviewed about 3,599 articles, and their results were similar to mine, that antiseptic barrier caps will help reduce CLABSIs compared to standard protocol. So that is all that I have for my project. Thank you for listening. On the next 2 slides, I have my references. And here is my second slide of references. Thank you.